Okay, so welcome to the 13th session. Today I thought we will discuss miscarriage because it's a common topic and there are maybe some misconceptions about it. So you need to be very thorough with the topic of miscarriage. Now, it's something that we as clinicians and you all as house officers, and if you are going to practice obs and gynae, we are going to meet all the time, and then we need to manage these patients. Before I start off, I want to remind you of one thing. Now, there's a very large project going on called O2 Life, which is a joint project by the Lions Club, the Sri Lanka College of Internal Medicine. Those are all the physicians that are involved in treating the COVID patients, who we call specialists in medicine or visiting consultants or visiting physicians, right? Those are VPs. And also the large umbrella organization is called the Ceylon College of Physicians, where all the neurologists, the cardiologists, everyone is involved. So these two colleges, with the collaboration of the Lions Club, has launched a very large project. The project total cost about 2.5 billion, right? That is 2,500 million, right? And it involves in supplying equipment to 191 hospitals in Sri Lanka. It's not just for COVID itself. It's a project that will have quite an impact on the management of all patients in the future, because the aim is to upgrade all the hospitals from provincial hospitals upwards, and not only the centers, but all the peripheral hospitals as well in Sri Lanka, from Jaffna to all over Sri Lanka, right, in all districts. And therefore, please go to the website o2life.lk, and then please share it amongst, because I think there's about 2,040 people here, and a lot of now there are now sites that can be shared, plus the information, and media conferences have taken place. So my request for you all, please share this on your social media sites and Instagram, Facebook, or whatever you are using, Twitter, whatever, and so that it can help this project. It's a project that has will have and have a very big effect on the management of patients now and for the future. So we'll be ready for to face any pandemic of any sort, especially the respiratory pandemics, by supporting this venture. So please share it with all that you know and support that as well. Okay, right. So starting off on miscarriage, about subject matter. So let's look at miscarriage in general. It's the commonest problem that we are going to meet as gynecologists in early pregnancy. That is the commonest clinical presentation of all problems that we will meet in early pregnancy in women is miscarriage. If you look at the definition of miscarriage, now miscarriage means a loss of pregnancy, right, and before viability, right, which is what miscarriage means. Now, if you look at the total amount of pregnancies that happen, right, what would we call a pregnancy? Right? Now, human reproduction, or the chance of putting out a live baby, is very small. It is not very effective. What does that mean? Say when the sperm and the ovum meet, right, and when the first cell forms, as you all know, it forms at the end of the tube, right? The ovary ovulates and the ovum comes out of the ovary, right? It comes out It doesn't explode. It just comes out very slowly. Okay. And then because there's a change in the chemical environment around that, the ends of the tube detects it. And the fimbrial end moves over the ovary to take up the ovum straight directly into the fimbrial end. Okay, so it's not a random process. And this is apparently mediated by chemotaxis. Because of the chemical change, the tube moves over it. The taxis is moving, right? So therefore, the ovum is taken directly into the fallopian tube. And at the end of the tube, there is quite a lot of liquid like a swimming pool, and the egg is swimming around for 48 hours, okay, until it gets absorbed. The sperm, once intercourse happens, will form a jelly because the spermatozoa or the seminal fluid is deposited at the end of the vagina, hopefully, if the person does the job well, okay? And therefore, it will coat the cervix, it will form into a gel, and then the best ones will swim in, right, into the uterus, and then the coagulum that forms will melt and it will come out like water, right? And then the sperm will go and live at the end of the tube where the swimming pool is, and if it finds a sperm, the ovum, there'll be conception, right? So even if ovulation does not coincide with intercourse, because the sperm lives at the end of the tube for about 5 to 6 days, so therefore there'll always be a store of sperm waiting for the egg to come if sexual intercourse happens 2 to 3 times a week, right? Or even twice a week. So therefore, ovulation need not coincide with sexual intercourse, right? And therefore, if you advise a couple to have sexual intercourse 2 to 3 times a week, right, throughout the cycle, because there are 2 ovaries, it can produce an egg at any time, then she has a chance of conception. Now, once this embryo, the first cell forms, it starts to divide, right? And then it has a long journey for 5.5 hours from the end of the tube, from the fimbrial end, until implantation. During this process, 30% of the pregnancies are lost, approximately. So that long trip down, about 30% are lost, right? These are all pre-clinical pregnancies, right? Because it usually does not produce enough beta-HCG during the journey down, because the trophoblast is not formed very well initially, okay? Because the trophoblast has to form, right, to implant, and therefore the beta-HCG is not produced in quantities that we usually detect in our pregnancy strips, and therefore it produces only a small amount. So therefore, during that trip down, which takes about 5.5 days, if it comes sooner, it will not implant because the trophoblast has not formed. If it comes late or is late somewhere in the middle, the trophoblast will form in such a way it can be invasive, and it will implant in the tube and we get an ectopic, right? So basically, the 5.5 days, this journey is modulated by the tubal muscle, the tube muscle, the cilia, the environment, the chemicals, hormones, everything must work perfectly to propel the embryo down the tube very slowly in such a manner it is not late or early. You all understand? So therefore, that is how a conception happens. However, during this journey, about 30% of the pregnancies are lost. Then if it comes to implantation, it needs to implant, right? So some of it might implant, but then the endometrium might reject it. Some of it may not implant properly, right? Some of it may not be in a stage to implant. And therefore, during this process of implantation, until a clinical histological evidence is found, this implantation process will cause another 30% of the pregnancies to get lost from the initial side, right? Then from implantation until viability occurs, or in the initial stages, when we can see signs of viability, which is a heartbeat, another 10 to 12 pregnancies are going to get lost from the time of where we have evidence of implantation until we see signs of viability, which is about, about 10% of these are lost. So altogether, from the conception point until we see a viable fetus, 70% of the pregnancies are lost. Okay, so therefore, only 30% of the pregnancies will survive from the onset where we see a heartbeat and a viable fetus until delivery. If you take the overall amount of pregnancies that happened, if you take a pregnancy, that means a sperm and an ovum has got together and formed the first cell, right? So out of 100 of those formed initial cells, okay, conceptuses, only 30% will make it, say, into a life form. Okay, so you and I and everybody are in that 30%. Okay, so you have to consider yourself very lucky, or I don't know, unlucky, whatever it is that you want to call yourself, right? Is that you are remember, a rare phenomenon of about 30% of 100 pregnancies that occur. Okay, you all understand? Where we are, what we are talking about now is that 10% from the implantation until a viability is seen. At the initiation of that, we discover as clinicians that this woman is pregnant. Okay, when we find evidence, whether it is biochemical or whether it is clinical evidence that there is a conceptus, okay, now we find out, okay, at to that point, 60% have gone, right? We don't even know about those, right? Then from that point until viability is reached, right, we will lose about, of those, we will lose about now 10 to 12% of these, right? We are talking about that 10 to 12% today. Okay, so of the time, so if you look at the whole amount of these, amount of clinically viable pregnancies now, which we discover, then we say, okay, about 10 to 12% of those will be a miscarriage, right? From that time, if we start to see a fetal heartbeat or a baby's heartbeat, the chances of miscarriage falls from about 10 to 15% to 2 to 7%. Okay, so if we start to see a heartbeat, right, that's a good sign, because the chance of miscarriage from there onwards is about 2 to 7.5%, right? But initially, if we see a sac or anything, from that point, if we still do not see a fetal heartbeat, the chance of miscarriage would be about 10 to 15%. Basically, 1/6 of the pregnancies will miscarry, and 5/6 of the pregnancies from that point onwards will continue, right? However, if you see a fetal heartbeat, what does that mean? About 2 to 7% will miscarry, but 98 to 93% of those will go on until the baby is born. Okay, so that is the information you need to carry about in your head, hopefully. Right, now, how do miscarriages happen? Is it the fetus itself or the baby itself that has problems, the embryo, or is it the endometrium? It's both. Okay, miscarriages can happen because the embryo has abnormalities, and that the embryo may be abnormal. Okay, it may be genetic malformation, it may be structural malformation. There's something wrong with the embryo, and therefore it miscarries. Okay, at the same time, it is thought that the endometrium, because it has to implant, the endometrium also may have defects. It's not thought that the endometrium is not sensitive enough, but it's actually thought that the endometrium is very sensitive in such a way that any type of embryo that comes down may get implanted a lot. So usually a bad embryo is rejected by a normal endometrium. But in some women, even the bad embryos are allowed to implant. So they have a better sensitivity towards implantation. Okay. And these, because there's a genetic abnormality and a problem, will come out as a clinical miscarriage later on. Right. So therefore, it is thought that the endometrium has more sensitivity for implantation, which will become a miscarriage later on. So basically what you need to remember is the reason for the miscarriages that we have found now is that they have genetic abnormalities, structural abnormalities, and also at the same time, the field of implantation, where they implant, right? Also there is a problem. So those are the ones that can cause miscarriages for these women. Okay, right. Now, let's just have a look at the risk factors. Who are more prone for miscarriages? The most important factor for all those is age. So it can be an elderly woman, right? And women are more susceptible to miscarriage after 38, 39, 40 years of age, right? And paternal age is also important as well. The more aged the male person is, the chance of a miscarriage in a woman he has impregnated will increase as well. So maternal and paternal age, of these, the most important thing relatively probably is the maternal age, because the eggs are as older as the woman, or even slightly older, because the eggs are formed in the intrauterine line. So therefore, there'll be more genetic changes, more abnormalities in the eggs that are released as time goes on, because the reproduction or the continuation of the cell divisions are arrested in the egg, and it waits activation when the sperm penetrates it, right? However, the more it is kept in a deactivated stage or a frozen stage inside the body, the more chances that small changes might be there in the egg. So therefore, there'll be more chance of having a genetic abnormality, and therefore there's a more chance of a miscarriage, right? Then so that is maternal and paternal age. Alcohol, yes. So the more the woman drinks, right, the more chances of miscarriage. But it is thought that if a woman drinks more than 4 units of alcoholic drinks per week, right, the chance of miscarriage also becomes slightly, about 2 to 3 times higher than a woman who does not drink, right? So anything more than 4 units per week might be detrimental. So it is thought it is better to advise women that it's better not to drink when they are trying to get pregnant, right? So the other thing is caffeine. Coffee or caffeine drinks. It has been found that if a woman takes more than 7 to 8 caffeine drinks, coffee, right, or any drink containing caffeine per day, the chance of miscarriage also will go up slightly. So therefore, it is best advised, and you can say that if a woman drinks a lot of coffee, a lot, 10, 12, 15, right, coffee day, maybe there is a possibility of slight increase in miscarriage. That is the evidence that was there in 2017 or 18. I don't know whether anything new has come up, but this is what I remember from about 2016, 2017, right? After that, I don't know whether, so you all are the young people, please check and let me know if you find anything else, right? Then, if there are uterine anomalies, septate, or any problem additions, the chance of miscarriage is higher. And we do not know whether, so especially when there is a septate uterus or uterine anomaly, the chance of miscarriage becomes higher, right? Then of course, the normal things like exposure to radiation, right? Those things might also harm the fetus. So therefore, however, you need to take a lot of X-rays to cause fetal damage. But however, radiological examinations in general, and especially any substance that emits radiation, all these, it is advisable not to expose the fetus or a woman who is going planning for a pregnancy to get exposed to all this. Any chronic disease like diabetes, heart disease, renal problems, cystic fibrosis, all these, any chronic disease can cause an increase in miscarriage as well. So it is, if someone is trying to conceive, it is best to make sure that if they have a medical problem, to make sure that it is under control, right? So generally, these are the factors that can increase the chance of miscarriage. But remember, the biggest factor of all are genetic abnormalities and anomalies, right? Are structural differences that can cause miscarriage. So that is the general overview of what you have to understand about miscarriage. Now, miscarriage is a huge problem in the sense it causes a lot of stress, a lot of grief, right? A lot of problems for women. They can have psychosocial problems, psychological problems. A lot of support is required, and a correct understanding as to what it happens is required, right? When you manage patients with miscarriage. Okay, right. Now, let's now look at what happens when a woman comes to us with a possible miscarriage. Remember, the term abortion is no longer used. Abortion is sort of synonymous with termination of pregnancy, right? And the women who come to us are trying to get pregnant. They want to have a normal baby, right? And they want to have a successful outcome to the pregnancy. And if you say, okay, you are having an abortion or getting an abortion, right? And this is an abortion, it is synonymous in the mind that it might be a termination of pregnancy, because that is also called an abortion. Okay, so therefore now the term abortion, remember children, are not used. Okay, and we always go with the term miscarriage. So let us have a small overview of what miscarriage means, or how this terminology is used. So there are times, remember, which we call biochemical pregnancies. What are these? The beta-HCG or the serum beta-HCG becomes positive. However, we do not see any signs of a pregnancy. The cervical os is closed, there is no bleeding, right? There are no other, might not be a bit of bleeding, but that is not very significant. But basically, the beta-HCG becomes positive and then it becomes negative. So she has had a biochemical pregnancy, which is something which is clinically, we don't see anything, but biochemically we say, so that's called a biochemical pregnancy. So that is the first thing that you need to remember. The second term in which you need to remember is what we call pregnancy of unknown location. So what happens in these are that the beta-HCGs might go up, okay, and they might be maintained for some time. We do not see a pregnancy inside the uterus. The cervical os is not open, it's closed, right? And at the same time, the beta-HCG will, with follow-up, it will slowly go down. So there was a pregnancy, but it is unknown because the beta-HCG is maybe quite high, right? So the pregnancies are unknown. It's somewhere, but is unknown. So that is what is called a PUL, or a pregnancy of unknown location, right? The third entity which you need to talk about is what we call a delayed miscarriage. What is a delayed miscarriage? A delayed miscarriage, or we sometimes call it a missed miscarriage, which may not be a very good term, right? Is where the baby or the fetus is not viable. We can see it. Okay? And she has not bled, or there are no signs. The cervical os is closed. She is not bleeding, or there may be a bit of spotting on and off, but not really, right? And the pregnancy sac is there, or the fetal pole or the fetus is there, right? There is no fetal heartbeat, right? And therefore, it's called a delayed miscarriage. Now, how do we diagnose that? When you do a transvaginal scan, and if we see a sac of more than 2.5 millimeters, 25 millimeters or 2.5 centimeters when you measure it, right? And if we do not see a fetal pole inside that, and it is completely empty, we call it a delayed miscarriage. The fetus simply has not developed inside. Or if there's a sac, and if there's a fetus or a fetal pole where from end to end is more than 7 millimeters, and if we do not see a fetal heartbeat inside, okay, then we call it a delayed miscarriage. In other words, if the gestational sac is more than 25 millimeters, we have to see a fetus in it. If we don't see a fetus in it, it's not going to grow. So it's called a delayed miscarriage. The other side is, if we see a fetus, and if the fetal pole is more than 7 millimeters, and if we do not see a fetal heartbeat, then of course the baby has died. So therefore, we will also call it a delayed miscarriage. Is that clear, children? Next, the terminology, what we call a threatened miscarriage. What does a threatened miscarriage mean? It basically means the fetus is live, but the cervical os is closed, but she is bleeding a bit. Okay? When the cervical os is closed, there is a fetal heartbeat, but she is bleeding and having a bit of pain. Then, of course, it is called a threatened miscarriage. So the os must be closed. We need to see a fetus with a viable fetus, because if the fetus is not viable, then it becomes a missed miscarriage. She has to have a bit of bleeding or a bit of pain, right? And that is how when we call it a threatened miscarriage. Is that clear? Right. From there onwards, we move on to the definition which we call inevitable miscarriage. What does that mean? We call it inevitable when the fetal pole or the fetus is live, but the cervical os, fetus may be live, maybe not, but usually the fetus is live, but the cervical os is open. So there's no way it's going to become, closed again, because if there's pain, the uterus is contracting, she is bleeding slightly, and we call it an inevitable miscarriage. Okay? Next, what you call incomplete miscarriage. What does that mean? The fetus has gone out, but there are retained products of conception inside. So the cervical os is usually open. She has had past clots. When you do ultrasound scan, there are products inside, right? And therefore, there we call it a incomplete man. Normally, the products are more than 1.5 centimeters of retained products of conception. We call it a incomplete miscarriage. Okay. And finally, what we call complete miscarriage is only if we have earlier found in an ultrasound scan a viable fetus, and now when we do the repeat scan, she has past clots, she tells us in the history, but now the cervical os is closed, right? And the products, retained products of conception, or we see the endometrial lining, the triple layer properly, or the products of conception is less than 1.5 millimeters in diameter, 1.5 centimeters in diameter. And that would probably tell us that it is a complete miscarriage. Okay, even if there's about 1.5 cm, it might, you can term it as a incomplete miscarriage. But remember, if the return products of concern is less than 1.5 millimeters, then we don't need to really do anything about it. You can still call it an incomplete miscarriage because there may be a bit of products, but usually we don't do anything at all. It will go out on its own, right? And complete miscarriage, by definition, is where everything has gone out. The cervical os is closed, and we see a proper endometrium with thin cavity, okay, thin line in the cavity, which is called a complete miscarriage. Do you all understand? So those are the definitions that we use. To recap, we have biochemical pregnancies, we have pregnancies of unknown location, we have threatened miscarriage, we have incomplete miscarriage, we have delayed miscarriage. In other words, it is called also miscarriage, right? And then we have complete miscarriage. On top of that, there is also infected miscarriages or septic miscarriages, which are induced. Different people will do different things to induce, which is rare in the developed world because these are legal. But we still find these septic miscarriages where certain people will try to destroy the pregnancy by putting something in, or putting in a some sharp object into the uterus through the cervix. So those can infect any sharp object that goes in and comes out, right? Will carry microbes along with it, and it will take off the same, go into the second combat. So then the infection will set in, and the baby will die, and then the body will start to push it out. It might end up in an incomplete or a complete miscarriage. At the same time, it can end up with as a septic shock, where the woman can sometimes even lose her life, right? Unless you quickly try and do an evacuation for that woman, right? I have seen several women die with septic miscarriages in my career. Luckily, they are less now due to the advent of easily accessible medical termination ways and means. Earlier, early in my career, we used to see a lot of septic miscarriages, and I have seen several deaths due to very serious sepsis with multi-organ involvement, where the women died despite evacuation and intensive care treatment. Okay, so luckily, those are very much less now, and we don't see those often. Although, yeah, several months ago I saw one, right? But however, due to the fact that we have good surgical care, good ICU care, antibiotics which are very potent, these lives can be saved even if they come with these septic miscarriages, right? Okay, so now we have got the definitions out of the way, right? And now let's look at the algorithm as to what we need to do when a woman comes. Remember, I'm not talking about ectopic pregnancies. So because ectopic pregnancies is a topic which we'll discuss later. I'm not talking much about preterm labor or second trimester miscarriages, which is a topic at a later date, as to there are things which we can do about it. I'm not talking about antiphospholipid antibody syndrome, which can, there are medical conditions that can trigger off second trimester miscarriages, okay? And also, today I am not discussing recurrent miscarriages, which is what? Miscarriage, 3 or more spontaneous miscarriages, consecutive spontaneous miscarriages, which the cause may be different, and that is a completely different topic. Okay, today we are discussing early miscarriages, and by definition, what does a miscarriage mean? The loss of a clinically discovered or histologically discovered pregnancy, right? up to 24 weeks is what is called a miscarriage. Okay. Up to 12 weeks, it is called an early miscarriage. And from 12 to 24 weeks, it is called a late miscarriage. That is the definition. Why 24 weeks? Because it is thought that this is the place where it's possible to make the baby live. Okay. Because early it was 28 weeks. Up to 28 weeks, it's called miscarriage. But now because of the advent of different types of medication, supportive care for the baby, intensive care, and then the surfactant, because of surfactant which can cause lung maturity better, right? This period has come down from 28 to 24. Okay, so now miscarriage is where up to 24 weeks it is called miscarriage. If the baby dies after 24 weeks, then it is called a stillbirth, right? Is that clear? So remember the definition of miscarriage, which is properly up to 24 weeks, and early is less than 12 and late is between 12 and 24. Okay, right. So now we have taken off all the definitions. Now we understand them. And then now let us switch on to how and what we do about this, right? Number one, now if a woman comes to us with bleeding and she's pregnant and she comes to us with bleeding, first of all, we need to find out or take a proper history and examination, look at the records whether she has had a scan before and it shows an intrauterine pregnancy or not, right? And once that is done, the most important thing is to do an ultrasound scan to find out exactly what the state is. However, there'll be a portion of women as house officers that you are going to meet who are going to come with a lot of pain, and the blood pressure may be low, and she is maybe sweating, right? And she'll be in a lot of pain, and she's the urine pregnancy test is positive, and she's discharging a lot of clots and feces. These are the women you need to do a speculum examination very, very quickly. Establish an intravenous line, put in a normal saline, put them on the examination bed, insert a speculum, because inevitably in these women who the blood pressures are low, the pulse is high, there will be products of conception stuck in the cervical os. The expansion of the cervical cervix with the clots will cause vagal stimulation, and that causes hypotension, right? And rarely women can even die with this vagal shock, right? And therefore, as house officers, put a speculum in, right? Look at the cervical os. If there are products of conception stuck there, take a sponge forceps, a Wrigley's sponge forceps, right? Catch it and remove the products from there. Immediately, the blood pressure will go up and the woman will start to feel better. Okay? And probably, or maybe you would have saved sometimes the woman's life by doing that. Is that clear, children? So those are the ones you need to take care of immediately. The next part, remember, is that we will do if she's bleeding slightly, and also we can go on to do a transvaginal scan. When you do a transvaginal scan, right, we will discover few things. Number one, she might be bleeding slightly, but there is no intrauterine pregnancy. Okay? What are the possibilities now? It can be, maybe you ask her in the history, did you pass clots? Right? If she says yes, then there is a possibility it might be a complete miscarriage, where the clots have gone out, the cervix is closed, and there's nothing in the cavity. So it might be a complete miscarriage. Second thing is, it may be just the very early pregnancy, right, where the sac has not yet formed. and maybe she's getting a bit of spots. There is a possibility, right? So it can be very early pregnancy. Number 3 is when the fetus or the embryo is implanting into the endometrium, right? It can bleed a bit, which we call decidual bleed. So we will see a sac, we might see a viable fetus and a bit of bleeding. So we'll have to call it a threatened miscarriage. Okay. Next, we might see a nothing inside, bit of bleeding maybe. We don't see an ectopic. So therefore, it might be a pregnancy of unknown location, or it might even be an ectopic. The next possibility is we'll be able to see the ectopic pregnancy itself. Okay, nothing inside the uterus, bleeding a bit, and there the ectopic pregnancy may also be there. Okay, so these are the possibilities that you might find. At the same time, yes, you can see retained products of conception, right? And if it is, of course, less than 1.5 centimeters in diameter, then of course, in our mind, okay, this will go out on its own. So you can just maybe leave it alone. Okay. Then you might see a lot of retained products of conception there. Then it is what we call a incomplete miscarriage. Okay. Next, in the scan, we might see a sac which is more than 2.5 centimeters across, but there's nothing there and a bit of bleeding. What is it called? It's called a delayed miscarriage. Okay. In the sac, there may be a fetus which is about more than 7 millimeters, but no heartbeat. Because if it is more than 7 millimeters, we have to see a heartbeat. If we don't see a heartbeat, then what is that? It is also a dead fetus, and it is also called a delayed miscarriage. Right? So these are the things we will discover. So we can diagnose either a delayed miscarriage, right? If there is, and in the speculum examination, when you see it, or before the scan, cervical os is open, but the fetus is still live, but the cervical os is open, and she's having a bit of pain and bleeding. What is that called? That is called inevitable miscarriage, because it's going to go out. Whatever you do is not going to help. You all understand? Right? We don't place cerclages before 12 weeks because the chances of genetic anomalies are very, very high, up to about sometimes 75–80% are genital anomalies. Even sometimes some figures have quoted up to 99%, right? So we can't retain that by putting in a stitch or anything. Even at second trimester miscarriages, if we think that it is an habitual or due to cervical incompetence and we try to put the stitch, there are 3 contraindications, remember, for a cervical stitch. If there is contractions with pain, no stitch. If there is bleeding, no stitch. And if there is leakage of amniotic fluid or the membranes are broken, no stitch. Right? So remember that. But that is beside the point, not here. So what I'm trying to tell you is when a woman comes with this, when you do a transvaginal scan, we see these, then we will have to diagnose appropriately what it is. At the same time, there's another category of patients who are going to come to you with bleeding, clots, and if their hemodynamically is unstable, blood pressures are low, if there are signs of infection, right, and if there is septic shock, right, and these are the ones we will need to go for immediate surgical intervention by removing these products of conception and emptying the uterus of this septic foci. Okay, and if she continues to bleed a lot and she's hemodynamically unstable, of course you will need to take her into theater, give her blood, right, remove all the products of conception by surgical evacuation, and then resuscitate her so that she does not die. Okay, so these are the types of women that they may be hemodynamically unstable, in septic shock, patients who are coming in severe pain with low blood pressure due to cervical products of conception. You take immediate action and do that properly. Then the other type of patients are the ones that you can offer different kinds of management. You all understand? So clinically, these are the women that are going to come to you where we will need to take the appropriate action. Okay. Now let us look at what we can do and what are the options of management that we offer these women, right? And that is basically 3 things. Okay. or shall I say 4 things. Number 1, do nothing, right? So if you look at management wise, okay, if you look at the whole type of management, you can divide management into groups. Number 1 is what? For anything, you can just leave it, do nothing, which I have taught you. Okay. So you need to be a good clinician to understand that there are instances where you don't need to do anything. Okay. So no intervention. Second thing is you can do medical management. Third thing you can do surgical management. Fourth thing you can do combined medical surgical management. And fifth, you can do alternative therapies, right? But however, alternative therapies are not included here. So we need to look at the other options of management. Now, if it is a biochemical pregnancy, we don't need to do anything at all, right? Just the beta HCG has gone up and gone down, and that is all. So it's a biochemical pregnancy. We don't need to do anything. Okay. If it is a pregnancy of unknown location, we do the scan, no pregnancy, not much bleeding, ovaries look perfectly all right, there's no free fluid, she's completely asymptomatic, but the beta HCGs are going there. What you do is you follow up with beta HCGs, and then probably you will see the beta HCGs slowly coming down. If it is going up and up and up, then you have to find out where the pregnancy is. But otherwise, you can, if it's coming down and then and we have never discovered where the pregnancy was, you name it a pregnancy of unknown location. However, that involves only follow up in your management, right? Then comes our complete miscarriage. So if the miscarriage is complete, and earlier we have done a scan and there was a, so we have to know that there was something inside also, and there's nothing inside now, right? Os is closed, then we diagnose at a complete miscarriage. We don't need to do anything. There's nothing much to do about it, unless you can, ask her to get pregnant again if she wants to, right? Then there is what? There is incomplete miscarriage. How is this diagnosed? There are products of conception inside, which is more than say 1.5 centimeters in diameter, right? Cervical os is open, right? And then in that instant, there are several options of management which we'll discuss. Second thing is, if we diagnose a delayed miscarriage, then also we can offer 3 types of management, which we'll discover now. Okay. Then inevitable miscarriage, there's nothing much we can do. We can just wait it out to see whether she miscarries, and usually that is expected management or conservative management where we use. So now I have taught you the types of management or approaches, and now we are going to talk about 3 types of miscarriages as to how we manage. What are these? One is inevitable miscarriage, and that of course we wait. So we'll keep that aside as well. We tell the woman, yes, the cervical os is open, you are bleeding, the chances of this continuing is very small, so we can work it out or we can wait. However, the other options are also available for inevitable miscarriage. However, when there is a live pregnancy but the os open, we are not going to do an evacuation at that point. The best way is to wait for spontaneous miscarriage in that patient, right? So now we are down to 2 types of miscarriages which we need to discuss management, right? The first type is what? Delayed or missed miscarriage, and the second one is what? Incomplete miscarriage. Okay, and the third type is threatened miscarriage. Threatened miscarriage, we don't do anything, right? We just let it be, right? There is no place for the movement for threatened miscarriage. In early threatened miscarriage, remember, there is no place for any type of medication. There's no place for progesterone. There's no place for cervical cerclage or anything. We just wait it out, because the reason being, it has been found that most of these are due to genetic or fetal anomalies. So there's no point in trying to return the pregnancy when the body wants to send it out, right? However, a large trials were done about progesterone, and there was a time when progesterone was given. Up to now, there is no evidence that progesterone will reduce the chance of miscarriage. So now progesterone, however, is widely used, right? So in a way, progesterone for women with miscarriage, progesterone in injections or in an oral form or a vaginal form may, this is just my opinion only, sometimes gives the woman a small psychological advantage as for her to feel that everything has been done for her, although this is not evidence-based, right? So therefore, sometimes when she has been expecting this pregnancy a lot, sometimes when she has been waiting for this pregnancy, and then she finally conceives, and then she starts to have bleeding or miscarriage, right? She would expect not maybe a lecture on the one that I'm trying to give you all now, right? But probably a medication or something that might help her at least psychologically to feel that she has done everything and the doctors have done everything for her to retain the pregnancy. So in my opinion, it is not harmful, harm has not yet been found, and therefore it might not be a bad idea to try progestogens, at least for the psychological effect that it might have on this patient, but it is not evidence-based, okay? So properly, progesterones have no effect on reducing miscarriage. It is thought that it is the failing pregnancy that reduces the progesterone in the blood, because all this evidence was based on what thing? When women started to miscarry, progesterone was tested in the blood, and suddenly the progesterone was found to be low. So it was postulated that it is the fall in progesterone that is causing the miscarriage, right? And then people started to give progesterone. However, nothing much happened. So later on, it was found that it is the failing pregnancy that makes the progesterone fall, and it is not the fall in progesterone that causes miscarriage. And therefore, there is no point in giving progesterone for early miscarriages. However, progesterone has a huge evidence-based impact on second trimester miscarriages and preterm labor. Okay, that is a difference. That is fully evidence-based and it is used. What I'm talking about is early miscarriage up to 12 weeks. Okay. Next is what? So we offer these women 3 options, right, for miscarriage. That is for delayed miscarriage and incomplete miscarriage. What are these options? Number 1 is wait it out, or conservative or expectant management. What do you say? Look, you are bleeding, your fetus is not viable, right? And it is a missed or delayed miscarriage, and therefore you might spontaneously miscarry. So therefore, we can wait. And when we can wait, we can, if the woman has no other problems, right? If hemodynamic is stable, asymptomatic or does not have much symptoms, not in a lot of pain, they can even wait up to 8 weeks or more, right? Which you can discuss with them. We will wait for you to miscarry spontaneously without giving you any medication. This has given a lot of advantages for women, and psychologically, they are happier with that form of expectant management, and the satisfaction of managing it that way is thought to be over 80–90%. A lot of patients will like that approach. So it is something that you can offer, right? For patients, if they are not hemodynamically unstable, if there are no signs of infection, then this is a very, very good form. One thing is, by waiting, 70–80% of the women will miscarry, especially in women, especially if there is signs of incomplete, especially signs of incomplete miscarriage, chance of completely evacuating everything is more than 70 or 80%. Okay. However, if it is a missed miscarriage, expected management may be successful, maybe in about 50 to 60%. You understand? Maybe about 50-56%, where expected management is successful. Missed miscarriage, where the fetus is dead, or if there's no fetus with a more than 2.5 centimeter gestational sac, only we wait for 6-8 weeks maybe. These studies are for 14 days normally, still being done. At the end of 14 days from diagnosis, the chances of the retained products of conception in a incomplete miscarriage going out is about 70 to 80%. However, only 50% of the sacs would have patients would have miscarried if we wait or have expected management at the end of 14 days if we wait. However, if we wait more, right, for about 6 to 8 weeks, then the chance of miscarriage, spontaneous miscarriage, becomes higher. So when you offer this to women, what are the advantages? No surgery, no medication, and the body throws it out. And therefore, it carries significant advantages, right, which you can offer to the women without a danger to the woman. What are the contraindications? Chance of infection, or if there are signs of infection, or if there's hemodynamic unstable, or if there's a lot of bleeding with the hemoglobin have come down, then of course you have to offer other forms of management. Clear? The second thing which you can offer women are medical management of pregnancy, which probably now has become almost the mainstay of the management of missed miscarriages. Okay. And how do we do that? We give initially, it's a drug called misoprostol. And what does misoprostol do? Misoprostol induces contractions similar to the one in a natural miscarriage, right? And when it induces contractions, it throws the fetus out. So we give misoprostol. And how do we do it? The evidence for the moment is to give 800 micrograms of misoprostol vaginally, right? And for incomplete miscarriage, if you want to use medical management for incomplete miscarriage, where the cervical os is open and there is more than 1.5 centimeters of products inside, and you don't want to evacuate, and if there's no signs of infection, then you can put in 600 micrograms of misoprostol to induce miscarriage. You all understand? About 80% of the women, close to 80% of the women will miscarry or have a miscarriage when induced by misoprostol. Remember, waiting for it to go spontaneously, it's more effective when there is incomplete miscarriage and when the cervical os is open. However, if there's a delayed miscarriage with no bleeding and if she's asymptomatic, and if you wait, it might not be successful in a certain amount of patients. And therefore, it is thought that it is very successful in treating patients with missed miscarriage or delayed miscarriage. This one and the same, right? And what is the evidence-based approach? Misoprostol, 800. If women do not want to take it vaginally, it can be used orally or rectally, right? However, the best form to use that to avoid the bypasses of the gastric bypasses is to use it vaginally, and it can be out. So you can wet it with a bit of saline and insert the it's 200 each, so 800 will be 4 tablets. Now comes the question whether the usage of mifepristone. Now, misoprostol is a prostaglandin analog, which induces contractions, right, and miscarriage. Whether the use of mifepristone, which is a progesterone antagonist, whether it increases the chances of a miscarriage, lot of evidence and lot of controversies. right? However, what the mifepristone does is it takes the conceptus out, or it dislodges the conceptus, especially in a miscarriage, it dislodges the conceptus from the uterus. Then once it is dislodged, then you have to give misoprostol in combination for the fetus to get expelled or the pregnancy to get expelled. So therefore, it is thought that this might increase the chances of having or completing the miscarriage above using misoprostol alone. So sometimes in miscarriage, and which is resistant normally to normal just waiting, so you might want to use mifepristone as well. But this is unit-based management. Different hospitals, different units might combine mifepristone, and in some countries it is not licensed for this purpose, so therefore it may not be combined. So therefore, usually misoprostol, and in some countries misoprostol is also not licensed. So therefore, the woman has to sign that they understand that this is not a drug that is not licensed for this purpose, right? And then use it. So now, how is mifepristone used? Normally, 200, it's milligrams, yeah. 200 milligrams of micrograms, I can't remember now, is given orally to the woman. And we wait for 48 hours. And then we use misoprostol, right? So we wait for about 48 hours for it to work and for the conceptus to dislodge. And then you give misoprostol 800 micrograms vaginally, so that the uterus contracts and sends it out, right? Okay, so that is what is used for the medical management of. So different regimes or different things can be used. Remember, for if it is used for incomplete miscarriage, it is 600 micrograms, and if it is used for delayed miscarriage, it is usually 800 micrograms of misoprostol. Okay, can and may not or can be combined with mifepristone depending on the unit policies and the permissions that are there in different countries at different times. Okay, for the usage of these drugs. So that is how medical management is done. Next, we move on to surgical management. And now, how is surgical management done? Is if surgical management is done, number one, if the woman says, look, I can't wait, if she has a social calendar where I say she has certain things to do, and therefore I do not want to wait, then of course she might choose surgical termination or surgical evacuation, not termination, surgical evacuation over medical management. Because still, if the medical management fails, then she has no option but to go for surgical management afterwards, right? And if she chooses surgical management, the advantages are there is a time for it. Okay, you come, you get it done, and you go home. So there's a time limit, and she can get a problem sorted out at a set date, at a set time, right? There's no waiting. Then definitely if she's hemodynamically unstable, definitely if there are signs of infection, definitely if she's having a lot of bleeding and a lot of pain, then you might opt for, because if the woman is in a lot of pain and then it's not controllable with other, and you can't just wait because she's in pain, then of course surgical evacuation is a very, very good option. And especially where definitely when she's in, if she has signs of sepsis and hemodynamic unstable, yes, surgical option is the best. So there you have to put her under anesthesia, and then you need to evacuate. The best way to evacuate this is by suction evacuation with a vacuum suction evacuation, right? There are special cannulas where there are openings, and these cannulas have openings on the sides, not on here, because they can go and stick onto the uterine wall with a vacuum, and then there won't be any suction. So the suction cannulas, the opening is at the top, so it can be put in, and then the suction will cause all the protein products of conception to be sucked in. So the best is Best is by suction evacuation. It can be done under ultrasound guidance if necessary to make sure that everything has gone out, right, which is not the usual practice. Or then otherwise you have to do sponge forceps. You have to evacuate it by with using the Wrigley's forceps under anesthesia. And then sometimes blunt curettage may also be used. However, blunt curettage might damage the uterus more, and it also can cause adhesions. It is thought that adhesions are formed whether if you do curettage up to about 30 to 40%, but in the long run, it does not cause any huge difference to the fertility rates. However, if you do very violent, sharp curettage, right, you can damage the endometrium and therefore can cause adhesions and what we call Asherman syndrome. And she can have a lot of problems with infertility and pain later on. So you need to be very, very, very gentle when you do that. The other thing, when you do surgical curettage, there can be complications like damage to the uterus and the cervix. You can rupture the uterus, especially if there are fibroids there and they are very soft during pregnancy. When you start to try to evacuate with the curette, you can damage the uterus. And if you do that, then you might need to do a laparoscopy to see the damage and repair it laparoscopically. And sometimes some might want to even do a laparotomy. Remember, when you are doing a curettage, if something yellow comes out, okay, that is the omentum. So if you see something yellow, when you pull out, and if it is yellow, please, please, please don't pull some more to find out whether what it is exactly. Yellow means omentum. There's nothing yellow inside the uterus. Leave it like that and do a laparoscopy or a laparotomy. Is that clear? Right? Because all of you all probably, if you are doing obs and gynae in the future, will be doing these evacuations. You see yellow, you stop, right? And if you are the youngest guy in the theater, you call your seniors, right? And tell the anesthetist you have perforated. If you are the consultant, then you say, okay, I see yellow, I stop, and you do a laparoscopy or a laparotomy to make sure that you have not hurt the bowel. Okay? So remember that when you are doing this suction evacuations or evacuation of the retained products of conception surgical, right? So these are the things that you have to know about these three options, right? And of course, once that is done, then she might require antibiotics, normal recovery, and then she goes back to a normal life afterwards, right? So what are the other things? What are the things that we can do to prevent miscarriages? Nothing much, right? Because almost all of these are genetic anomalies. So therefore, we can probably, there's no way which we can prevent this, right? What are things? Few possibilities. One is try, I don't know whether they are new things, but if you drink a lot of coffee, maybe you can advise them to drink less, right? More than 7, 8 per day, maybe less. Alcohol, definitely, right? If the woman is taking more than 4 alcoholic drinks or units per week, then of course it will increase the chance of having miscarriage 2 to 3 times. So you can advise them not to drink. Smoking, controversial. There a lot of studies have been done, no conclusive results that the smoking increases miscarriage. From the evidence, this is about 2017-18, maybe, I don't know, the last 3 years I have not looked at the evidence actually. So if you all have any new evidence, please tell me. But even the largest trials have not shown any significant change in the miscarriage rates due to smoking, right? However, it is good practice not to smoke, okay? But it increases all the rest of the problems, right? So therefore, but specifically towards miscarriage, there is not much evidence, right? Make babies while you are young, okay? That definitely will reduce the incidence of miscarriage because it is evidence-based that the older you get, the higher the chance of miscarriage. Pre-conceptional genetic diagnosis, that is checking whether the embryo is normal before in vitro fertilization by taking a small cell and from the embryo before implantation and putting it after checking has not made any changes in the chance of miscarriage. However, in in vitro fertilizations, there are certain medications that is thought to increase the chances of implantation, and there are certain ways which it is thought that you can increase the chance of conception by looking at the window of implantation, by diagnosing exactly when it is the best time for implantation, giving certain medications, but those are very IVF specific things which can be done, which are not usually used in normal practice. All the rest of the evidence about immunomodulation, suppression of immune problems, tumor necrosis factor inhibition, this, that, everything, all this all are not evidence-based. So basically, there are not many practices or medication which you can reduce miscarriages, unless the other ones which I told. So basically, try to have babies at a younger age. Try to, because the paternal age, try to select someone younger, okay? So that also might help in reduction in miscarriage. Then have all the diseases which chronic diseases need to be controlled. That definitely will reduce miscarriage. Maybe less caffeine intake, not very sure. Alcohol, definitely, right? That will, so try to drink less, okay? So those are the things that are evidence-based, and other things are not really evidence-based about the reduction in miscarriage, okay? So that sort of concludes an overall general overview of measure, and that should be more than enough for you to answer all the questions, right? So now, what are the questions you have? If expectant management is offered, does it justify to give prophylactic? I don't know, because if there are no infection, then if there is infection, you cannot give do expectant management. If you are doing expectant management, there is no reason for us to give antibiotics, because if there are reasons of signs or symptoms of infection, then of course you can't do expectant management. You really need to go ahead and either do a surgical, better do a surgical management at that point, right? So antibiotics are not indicated at all in expectant management, right? Antibiotics are given based on the fact or a mistaken fact that it is the infection that is causing miscarriage, which is not evidence-based. You all understand? If vaginal infections are causing miscarriages, that is thought, the only thing that can, I'm talking about less than 12 weeks, right? After 12 weeks, miscarriage or mid-trimester miscarriage may be caused by urinary tract infections, which you know. Also, there is evidence that vaginal, asymptomatic bacteria can cause. So there are antibiotics may be indicated. There's another thing that bacterial vaginosis might cause miscarriage. In that case, if she has had recurrent miscarriages or second trimester miscarriage with a live fetus, then of course it is indicated that you might use certain medication to reduce the bacterial vaginosis or organisms that are connected with them. But in miscarriages, where the fetus is not live, we are talking about a fetus that is not live, okay? Right? We are not talking about a live fetus, because we don't induce, or we don't do expectant management, or you don't do surgical management, or we do not use medication for a fetus that is live. Is that clear? So it has to be for a miscarriage, which is called a delayed miscarriage, and that is the only, that is why we are talking about the 3 options, okay? Anything that is live, there are, those are other entities which we are not talking about today, okay? Next question. When can we advise a woman to get pregnant again following miscarriage? There is no set times, right? The old habit of saying wait 3 months is nonsense. See, when the woman is ready for reproduction, the body will show it by causing her a menstruation, because she's ovulating. Okay, so there are no specific times. One woman might within the next cycle she can get pregnant if she has ovulated. So when the body is ready, she can get pregnant. So you tell the woman, take folic acid. If there are any chronic diseases or factors that you identify that might cause problems, tell the woman that you need to modify those, and then she can, there's no specific time. I forgot one thing, remember, for any woman who is rhesus negative, you will need to give anti-D prophylaxis. Any woman who we do surgical intervention, whether less than 12 weeks, right, we have to give anti-D prophylaxis. Any woman we are doing medical induction, right, even under 12 weeks, we have to give anti-D prophylaxis. Any woman who is having a spontaneous miscarriage, but the bleeding, expectant management and bleeding still continues after 12 weeks, you need to give anti-D prophylaxis. So remember that, please. If they are not isoimmunized, make sure that they are given anti-D prophylaxis. Next question. Is it better to give misoprostol as a divided dose or as a full 800 micrograms once a day? Just 800 micrograms immediately, no divided doses. The divided doses are given when you want to induce if you are trying to at a higher period of gestations, right? So therefore, the amount of misoprostol will become smaller and the doses will be divided, right? So if you have an intrauterine death, we are not talking miscarriage, at about 24, 26 weeks, then you can do misoprostol injection, but with very small doses, but divided. Okay. However, having said that, you have to remember there are different regimes which have been used, right? But usually the best for the moment is all together in one shot, right? If retained products between 1 centimeter and 1.1, do we put on antibiotics? No, there are no need of antibiotics if there are no signs of injury. You just let her go home and then ask her to come back after the next period, or if she has passed close, to make sure that everything has gone. However, if she is develops fever or discomfort or smelly vaginal discharge, you ask her to come back, where you will need to do a surgical evacuation. Okay. Other than patient wishes, does the product thickness is a deciding factor for deciding management option in patient without infection or immunosuppressive? Other than patient wishes, does the product thickness is a deciding factor for deciding management options in patients without infection? Yes. If the retained products, most of the studies has taken a cutoff mark of 1.5 centimeters, right? Which means if it is less than 1.5 centimeter diameter, there's definitely no reason for us to do a surgical evaluation, right? However, she continues to bleed on and off with a product thickness of less than 1.1, you might consider medical induction with misoprostol if you want, but usually you don't require it because it will go off on its own. I personally, I will, if there's no hemodynamic problems and if there's no infection, I personally will even ask them to do conservative management without any form up to 2.5 centimeters in diameter. So there are various studies starting from about 1.5, but less than 1.5, definitely you don't need to do a surgical evaluation. But I normally will, personally, I will wait even with 2.5 for it to go out spontaneously, unless there are no other problems, right? However, remember the cutoff mark is 1.5, that is evidence-based. Is there evidence to say that long travel or sexual intercourse causing first trimester miscarriage? No. Travel is not contraindicated. Flying by air, right, by aeroplanes or spaceships or whatever is not contraindicated, right? It does not cause miscarriage. Sexual intercourse causes, no, it does not cause, no evidence to say that sexual intercourse causes miscarriage. Does it mandatory to do an ultrasound scan before discharge in a patient who underwent medical or surgical management? Yeah, because you do a, it's not mandatory, but it is preferable if she has had medical management. It's mandatory because you put in something, medication. If things have gone out, you need to find out whether things have gone out or not, or whether the products of conception are still there, or whether the stack is still there, right? Because just because you do medical, there is no 100% success. You just have to check. So it's mandatory, right? Surgical management preferable, because once you have done that, to make sure that everything has gone out, you can do an ultrasound scan. However, it's not entirely necessary, because surgically the chances of having retained product is about 4 to 5%. failure of your, you do it, but still some products are there. That is about 4 to 5%. So therefore, 96% of the time you would have evacuated everything. So it is not absolutely essential. If you are really sure of your surgical management, it will do a scan, but preferable to do it before she is discharged. Of course, you can do a follow-up scan later on after surgical management. Is there any place for oxytocin to start contractions in miscarriage? No. Oxytocin, remember, is a drug which the uterus is more sensitive at the later stages of period of gestation. Why? How it becomes sensitive to oxytocin is the amount of receptors per square millimeter increases a huge amount closer to labor. However, in a small uterus, which is about 12 weeks or less, the amount of oxytocin receptors per square millimeter is very, very small, right? And it is not, and the receptors are not sensitive. So oxytocin does not cause any contractions or does not increase the chance of having a successful medical sort of induction. Do we do ultrasound scan to all women presenting with TD, even if it is spotting? Yes, definitely, because if there is spotting, so it may be a miscarriage, right, or a threatened miscarriage. So definitely ultrasound is in. So there is no place for no ultrasound scan, please. Okay, that is very old management practiced by maybe a very small number of people, but definitely 100% you need to do ultrasound scan. So otherwise, how else are you going to? Because we don't have specific powers at the tips of our fingertips to look at the baby, right? Is there a specific way to monitor a patient's vitals, or is 3 times a day sufficient? For what? Is there a specific way to monitor a patient's vitals, or is it 3 times a day sufficient? Why do you need to monitor vitals? Miscarriage in a patient, if it is not a suspected ectopic, you don't need to monitor the vitals, right? Once or twice the routine monitoring is more than enough, right? So there are no specific ways, right? So if she's miscarrying and if she's losing a lot of clots, then of course you need to monitor vitals. Otherwise, if she's just bleeding on and off, there's no need to do a very intensive monitoring. Is not really required. And definitely, if you know it's an intrauterine pregnancy, and if you are managing a conservative, she can basically go home and come back. You don't need to keep her in the ward. What is the role as a house officer in an illegally induced miscarriage? Right. Now, house officer, there's no role actually. Okay. So now, it's like this, children. Now, miscarriages, earlier we used to report every suspected termination or illegal termination of pregnancies, right? Now it's not that much practice because it's a huge shall we say a huge psychological problem for the woman. But where you had, when you report these cases, the authorities will come, they will start, the woman is not going to tell where it happened, what happened, right? Then there's a lot of unpleasantness. Usually these spots are never closed down, right? So usually the house officer, and of course, if the woman says that a termination has been illegal, termination has been done, as a house officer, it is your duty to report it to the consultant. And the consultant, depending on the circumstance, because the patient is under the consultant, will make a decision as to whether it needs to be reported to the police or not, right? So there are instances where I have chosen to report these very specifically, because if there's a lot of harm has been done, and if there is harm to the uterus, cervix, right, where if, of course, as a consultant, if you feel that it's dangerous to the women's lives and all that, then of course these need to be reported. Especially interventions definitely will need to be reported, right? However, now what is happening is the interventions are no longer physical interventions. Almost all these women now come with medical interventions. Okay, and therefore, now it has become freely available. And buy the tablets anywhere. People sell the tablets, they are online. It's very difficult to regulate. And therefore, and these women will come to us and say, I started bleeding. So there's no way which you can prove or say anything or anything unless they come out and say, look, I took tablets, right? It's not going to happen. So therefore, the chances of you as a house officer finding out something that has happened is very, very small. Okay. So earlier, yes, there were a lot of interventions that needs to be reported because these people are harmful to the society and they can kill women due to septic abortion. But now, as house officers, if you have a suspicion, please tell your seniors and let them take the decisions. Okay. How long can you wait for expected management before going ahead with medical management? Up to about 8 weeks. You can agree to 2 weeks, 3 weeks, 4 weeks, 7, even 8 weeks. You can go if there are no problems. Right. That seems to have covered most of the questions. Anything else? You can ask if you want to. So I think we have covered all of miscarriage. Yeah. So I don't need to go back to it. Now just tell me what you all want for next time, because next time is obstetrics, as I understand, right? So what is the topic that, can you type in a few topics, whoever is left and who is not too sleepy? Obstetrics topics, quickly type in a few or tell me whatever you want. Yes, few topics so that I will decide on what to do. APH, assisted delivery, hypertension in pregnancy, abnormal labor, okay, shoulder dystocia, reasons isoimmunization, hypertension in pregnancy. Right. So enough topics. Okay, let me just think about this. Yeah, PIH. Diabetes in pregnancy. Diabetes in pregnancy, I covered no child. So that shows who is this young man or lady who has not looked at my lectures. It says galaxy, so it is hiding. He or she is hiding. Go and look at all. I have comprehensively. I did that, right? I can remember I covered diabetes in pregnancy. Yeah, okay. Right. Nidhi Mate diabetes in pregnancy. Right, okay. Okay, I'm joking, child. Now I said sorry. Don't worry, don't worry. I'm joking. Right. So, right, okay. So I think there are enough topics for me to think about. So next time we'll do it. And remember, children, I want you all to do me a favor, okay? Share the O2 Life today, now. Right? Right? Okay. Okay then. Good night then.
Good night, sir. Thank you.
Bye.